about you see what you look for, and you look for what you know, may be modified a little bit when you find something that seems to be true that goes against what you know. Then true knowledge starts to move forward, and this is what the spirit of science is all about. And as I've talked with some of my colleagues here, one of the themes that I've heard more than once is that unfortunately we don't have the finances to do research on what we do. We're very busy clinically, so we don't have the money to carry out research projects. I'd like to respectfully point out that you don't need to have a lot of money to do research. You simply have to observe carefully your patients and record what you see. And when you start to see things that don't match up with what you think you know, then life gets very exciting. And the field of brain injury rehabilitation has moments of quite exciting, satisfying work, and other times it can be rather tedious and not very exciting. But if you're constantly learning something new from the patients that you work with, then it sustains your creativity and I think results in better care for your patients. It's against this background that I'd like to kind of introduce this morning something that I observed early in my clinical work that has preoccupied me for a number of years. I was perplexed by the fact that many young adult brain injury patients seem to minimize or not be fully aware of the neuropsychological problems that seem so obvious to those of us around them. Was this really a method of coping? Was this a denial over some rather serious losses in their life, or were they really not able to recognize or appreciate that they were as impaired as those around us felt they were? This topic, as I've said, has preoccupied me for a number of years, and what I'd like to do today is to try to summarize, by way of introduction really to the workshop, some basic ideas about how would we actually define what impaired self-awareness is, and how does it relate to the traditional neurological term of anosognosia, as it exists not only in traumatic brain injury, but in many forms of brain disorder. I then would like to just briefly describe how this became an area of focus in terms of our early interventions in neuropsychological rehabilitation. And then I'm going to summarize, admittedly, a series of selected and perhaps biased findings that at least helped me improve my thinking about this problem, because I discovered things that I had not anticipated seeing. And then to talk about a model that has been useful to us in terms of managing these patients. Because there's a lot of distress in the rehabilitation teams when they do not fully understand this problem and when they approach it in less than clinically sensitive ways. It can result in a lot of frustration for the patient, a lot of frustration for the family. So I'm going to do this by way of, again, of introduction of the workshop. Anosognosia refers to the clinical phenomena seen in neurology where a brain dysfunctional patient does not appear to be aware of an impaired neurological function, and it has been broadly expanded to neuropsychological function as well, that again is obvious to the clinician and any other reasonably attentive individual. It doesn't require medical training to be able to detect the individual does not seem to be aware of a rather significant loss in function. What is interesting is that this lack of awareness appears to be specific to individual deficits and cannot easily be accounted for by the level of arousal of the patient, that is if they're obtunded, or to widespread cognitive impairment where they seem to have difficulty evaluating any information. Impaired self-awareness is at times used interchangeably with the term anosognosia, but I believe should be used to refer to a partial or incomplete awareness of one's impaired neurological or neuropsychological functioning. If you will, you could use the term aphasia or dysphagia, implying a complete loss or a partial loss. And I think the field would advance if we left the term anosognosia for those in which there was a clear, complete loss of awareness, and impaired self-awareness where there is a partial awareness. I've told this story a few times to colleagues, and I will tell it to you as well. I can remember when Dr. Ben-Yishai was a consultant to our program in Oklahoma City. I was walking him to his plane in the airport, and I was asking him, I said, you know, I'm impressed that many of the patients that we work with do not seem to be fully aware of their difficulties. For example, a patient might admit that they have some mild memory difficulties, but it was of no consequence. They knew that they could still carry out their ability, their day-to-day activities, they could work and so forth. And it's one thing to hear this glibly in an interview. It's another thing to bump into it daily when you're working with patients 5 days a week, 6 hours a day, and you repeatedly get statements from them that they seem to see the problem as less severe than what you see the problem. And I remember as I was walking with Dr. Yehuda Ben Yishai to his plane, I was asking him about this, and I said, what did Kurt Goldstein say about this? And Goldstein's writings really said that this phenomena, which he was aware of, he saw clinically, just as we see today, he said this is a defense, a biological defense, not a psychodynamic defense. This was a biological defense against the catastrophic reaction. Many of you may know the term catastrophic reaction, some may not, but Goldstein described in his rehabilitation work with brain injured soldiers that in the midst of their doing a variety of cognitive tasks, they may suddenly become overwhelmed. They may suddenly become quite emotional and upset, as if a catastrophe had just occurred. But it was often not obvious that they were about to have this emotional response. And he said, when the individual's abstract attitude failed to function normally, and they suddenly came face to face with the reality that they could not do something and that in the past they could do easily, they would become emotionally overwhelmed. Norm Geschwin, a famous neurologist in the United States, once made the comment, I heard him make a comment at a meeting, I've never seen a catastrophic reaction. Well, I would respectfully say if you work with patients in rehabilitation, you'll see it all of the time. If you do a brief neurological examination, you may never see it. But if you actually spend time with the patients, you see it a lot. So we talked about this. What was the actual cause of this? And again, Yehuda at that time suggested to me this is the way Goldstein viewed it. And I struggled with this for quite a while. Was this really a defensive reaction, biological or psychodynamic in nature, or did the patient not simply understand or appreciate or have insight as to what was wrong? You may say that's an interesting theoretical issue, but how does it relate to rehabilitation and rehabilitation outcome? In our very first group of patients, we used a technique that Dr. Ben Yishai had introduced. He said on a scale from 0 to 10, with 0 meaning you're completely unaware of the effects of your brain injury on your day-to-day life activity, and 10, you are completely aware as a result of life experiences, rehabilitation, and so forth. You have complete awareness. We were struck by the fact that of the 4 patients that we had worked with, 3 for only 6 months and 1 for a year, that after this intensive work, 6 hours a day, 5 days a week for 6 months, after all this intensive work, the patients who were successful, and we can define that later in the workshops, said, I'm not completely aware. And independently, the staff who rated these patients on awareness came up with very similar ratings. In contrast, every patient who we deemed to be a failure, who the extensive efforts did not result in increased productivity, did not result in being integrated back into the home or family life, all of them said, I am completely aware after 6 months of work, 6 hours a day. That's what I want to emphasize. This is not 30 minutes 3 times a week. This is intensive work with patients. They insisted that they were fully aware, and staff who worked with them independently made their own ratings, said they were far from being aware. This phenomena has been studied more extensively over the years, and in the workshop we'll show you data that relates to how impaired awareness in fact is related to the process of neurological rehabilitation or neuropsychological rehabilitation and the outcome. Over the years, there have been many, many interesting observations, and some emanating from the more recent cognitive neurosciences, that give us little glimmers, little pictures of what may be responsible for this problem, but it is not well understood because there's no theory of human consciousness that has emerged that has been universally accepted. So we're always looking at this problem with piecemeal information. We do not have a complete integrated view. But nevertheless, there have been some very interesting observations that keep coming back to us, that keep reflecting what we know, and then some new observations that come back that are contrary to what we know, but open up insights as to what may be going on. Babinski was the first person to give us the term anosognosia, but I think the real genius in understanding anosognosia was not Babinski, was Anton. If you read Anton's early work, he was extremely perceptive in his ability to characterize patients that had a lack of awareness, not only for vision, they were completely cortically blind, but for hearing. And what he emphasized was that in these patients, we often see lesions that occur in a region that is known to be important for that function. For example, the occipital lobes as it relates to vision. It was also interesting that he was the first to emphasize the bilateral nature of these lesions, and he described them as almost symmetrical. As it turns out, that it probably has to do with the function that is involved, since vision requires bilateral inputs to the calcarine region. It would make sense that bilateral lesions are necessary for this kind of anosognosia. He also pointed out a very important problem that keeps coming back, we keep struggling with trying to understand this, is that even in the face of information, knowledge, feedback, the patient seems to discard or discount any objective evidence that he or she has lost his or her functional capacity. And this can not be explained again on the basis of a dementing condition. These facts need to be understood and analyzed in order to get closer to understanding the mechanisms responsible for true anosognosia. So if you look at if you just take Anton's classic example, in his autopsy studies, the lesions were not directly in the calcarine fissure. They were in the white matter projection areas very close to the calcarine fissure. And in more recent studies, which I should say are case studies, there are no group studies on Anton syndrome, you repeatedly find that it's lesions that are either right adjacent to the calcarine fissure or in the calcarine fissure per se that produce this startling syndrome. Bloomfield has a very interesting case study that he presents along this line, showing using more modern imaging techniques what Anton had observed much before that time. As I mentioned, Babinski was the term who gave us the word anosognosia, but actually Arnold Pick at the time Anton described the same phenomena actually. They recognized that patients had hemiplegia and for a period of time were not aware that their arm in any way was affected. Many, many studies have appeared over the years trying to sort this out. And we recently had a conference in Phoenix about 1.5 years ago that brought in a number of these people to present their studies and to think through what is our most recent understanding of these phenomena. And I've chose for this presentation to focus on work by Anna Maria Berthe. She was a student of Eduardo Biziak, and Biziak, in my mind, is the true insightful observer of anosognosia, whose ideas are really based on Anton's ideas. In this paper by Berthe, they specifically looked at the cortical distribution or anatomy that was involved in anosognosia for hemiplegia. And as you know, in about 93% of patients who have right hemisphere strokes that have anosognosia for hemiplegia, about 90 to 93% of these individuals also have hemi-neglect. And they were very interested in looking at the shared and different anatomy with those individuals that showed anosognosia and neglect versus patients who showed neglect only and not anosognosia. And in one patient in a series where the individual had anosognosia for the hemiplegia but no neglect. So in their study, what they report of many interesting findings are as follows. Patients who have neglect but are not anosognostic for their hemiplegia tend to have more subcortical lesions. That in itself is interesting, suggesting that somehow anosognosia has to do with the cortex. Second, these patients who had a combination of anosognosia and neglect, they tended to have a higher concentration of lesions in areas you'd expect them to be involved in. The dorsal premotor area, Brodmann's area 6, was damaged in 94% of these patients. Area 44, the opercular inferior frontal gyrus, also had a very high incidence of being present in these individuals. As has been known for many years, somatosensory loss and the somatosensory cortex is also involved in anosognosia for hemiplegia. If you look at these areas, again, I know there's if you look at these areas, that are compromised. Okay. There we go. They tend to be in this region right here. They can be a little bit more anterior and a little bit more rostral, but they tend to be in this area. Now, what was interesting is that when they also looked at these individuals, besides having the dorsolateral prefrontal cortex involved, they and subsequently many other researchers have started to demonstrate something that people had not looked for, and that is that the insular cortex, the so-called fifth lobe of the brain, was compromised in many of these patients. And in the one patient in which they found anosognosia but no neglect, again, the insular cortex was involved as well as the regions that are involved, as we've talked about before. And their argument, an argument that Busiak had made years ago, is that a lack of awareness of a given neurologic function may be modularly organized, that it's the same structures that are involved in carrying out that function, that initiate the function, that may be compromised when there is a lack of awareness of that ability. Now, the anatomy of this is well known to the group, but we look at the sensory portions of the sensory motor system. Obviously, what is important here and to keep in mind is that when projections go from thalamus, they just don't go directly to sensory motor cortex, they go to insular cortex as well. And many of us look for the insular cortex. Of course, you have to pull back the temporal area in order to see it adequately. Now, I'm going to tell you about a case that we recently had an opportunity to examine somewhat serendipitously that shows a very interesting dissociation. This patient is a woman who was 51 years of age who had an arteriovenous malformation that was actually ruptured about 5 years before we had seen her, was surgically managed properly, had no symptoms, and then more recently had another hemorrhage, which resulted in her being treated at another hospital, and then finally taken to the Barrow Neurological Institute, where our chief of neurosurgery is Robert Spetzler, Dr. Spetzler, who's well known for tackling these rather difficult problems. So we're able to see this patient with Dr. Spetzler's. And here you simply see the hemorrhagic consequences of the parietal AVM. And then, go back. In addition to this patient having hemiplegia and neglect, what was unusual was this patient had a subsequent bleed involving the posterior communicating arteries, posterior cerebral arteries, and was also blind. Now, when we saw her, she was completely aware of her blindness, but unaware of her hemiplegia. And to our knowledge, there's not been a case like this in the literature. There are cases where the individual has a hemianopsia and comes to be aware of that partial loss of vision, but no case in which the individual has had a complete loss of vision, was aware of that, had the hemiplegia, was unaware of it. When she was examined using neuroradiographic techniques, one of the pictures that we observed was this, where she has bilateral temporal hemorrhages, but you can somewhat see that they are not directly impinging on the calcarine fissure, and our neuroradiologist confirmed this. So she has involvement of these optic projections to the occipital cortex, but sparing of that cortex. What we were looking for was a hypothesis that arrived from our work with traumatic brain injury, and that is years ago I noticed patients who had severe unawareness or partial unawareness of their neurocognitive deficits often tap slower in terms of speed of finger tapping. They often tap slower bilaterally, even though the effects were most pronounced in the right hand. And so the hypothesis that we had was when this patient would recover from their anosognosia for hemiplegia, we had two hypotheses. One, speed of finger tapping would be bilaterally slow in the presence of anosognosia for hemiplegia, but when the patient regained awareness that that arm was in fact their arm, you'd see improvement not only in finger movement in the so-called affected hand, but in the unaffected hand. That was the hypothesis that drove this little case study. In this artistic representation, you have some of the characterizing the conditions we observed at different time frames. When the patient was clearly anosognostic in condition A and also showed hemi-inattention, we asked her to take her right hand and touch her left hand. She stops at the midline, of course, showing the hemisensory neglect. Then a step a little further, as she improves, still anosognostic, take her right hand and touch her left hand. She's now able to cross the midline, but touches the shoulder. And then finally it progresses to where she's able to find her left hand with her right hand. Now, this table shows what her anosognostic level was for hemiplegia. In the Biziak scale, 3 is complete unawareness. At that time, her speed of finger tapping was 0 in the left hand, and she was tapping very slowly in the right hand, something that we would predict. What should she be tapping? In a 50-year-old woman who's right-handed, the tapping score should be in the low 40s per 10 seconds. Also during this time, she had complete hemisensory loss on the left side, which persisted all through the period of time, even after the anosognosia for hemiplegia resolved. And as you can see, she also had subtle difficulties with her memory, which persisted throughout the same time. Sometimes people want to argue that it's the hemisensory loss or it's the memory impairment that is responsible for the phenomena, and this is not the case. Now, what's interesting is that just prior to showing some improved awareness, where she has a score of 1, her right hand substantially improves in tapping. But it is only when she is able to actually initiate movement in the left hand that the patient begins to have awareness of her difficulties. And this is graphically represented here, where we simply measure finger tapping over the course of the first 60 days of her recovery. Our hypothesis was not supported. I would expect it at the time that she was able to become completely aware, that would be exactly the time finger tapping improved. It was not. There was some improvement in the so-called unaffected hand, but it was really the improvement in the affected hand that paralleled the increase of awareness. And this is what Biziak and Berthe argued, that awareness is that awareness is the highest organizational level of a given functional unit or capacity. So there was an example that was a wake-up call. Not all functions was a wake-up call that if a function is not bilaterally represented, you do not need bilateral impairment to have true anosognosia. What led us to these hypotheses, and where are we now in understanding these difficulties and combining it with our understanding of what I would call just a basic psychological understanding of the patient, as opposed to a purely neurological or neuropsychological understanding? As I mentioned, years ago, we serendipitously found that the speed of finger movement was related to those patients who underestimated their limitations, but particularly their limitations in emotional functioning and in social interaction. For a long time, we were perplexed as to why such a simple task would have any correlation with such a complicated function. And the answer is simply that it is an indirect measure of the severity of injury. Soraya Dickman has done some very interesting studies looking at the neuropsychological outcome following severe traumatic brain injury. And in one of her papers, she looks at the entire, there's a battery of tests called the Halstead-Raytan neuropsychological test battery. It's not very popular in some settings. In other settings, it's more popular. But it has a lot of data regarding its reliability and validity. In this battery of tests, if you're severely impaired, your score is 1.0. If you have no impairment, your score is 0.0. And what Soraya Dickman showed, that if you looked at how long it took an individual to simply follow commands after severe injury, there appeared to be a dose-response relationship between the Halstead Impairment Index score and the amount of time it took the individual to respond in a meaningful way. This is a reasonable correlation of nearly 0.60. That's about as good as it gets in neuropsychological rehabilitation in terms of the correlation with generalized measures of severity. It's also interesting to see that finger tapping, which takes about 10 minutes, while not having the same level of correlation, is also highly correlated with the severity of these injuries. So our initial observation was that what we were picking up was a measure of severity of injury, and this is why it was correlating with this phenomena. Also in that study, we did an early attempt to look at CT and MRI findings and relate them to impaired self-awareness. And we found, and it left an indelible mark on me, the lesions were not just in the frontal lobes at all. The lesions were throughout the brain, and they even involved the cerebellum. These patients, by the way, besides the finger tapping, had no neuropsychological correlate with their unawareness, none whatsoever. Even the Wisconsin card sorting test and others did not correlate at all with this lack of insight or this lack of ability to appreciate the difficulties. So either our tests were insensitive or this problem was not related to what was known to be a domain of neuropsychologic dysfunction. Years later, Mark Shearer replicated the same finding, which we were happy to see, that it was not in a specific location, but lesions throughout the brain that correlated with this phenomena. Now, you've already had some excellent presentations regarding what are the areas that are compromised in traumatic brain injury and how it may be related to the various neuropsychologic deficits that we see. But I'm going to walk through just a couple of observations because it will tie in with, again, information that we will provide during the workshop concerning the correlates of impaired awareness and how it does or does not change with the passage of time. Dr. Zimmerman provided this slide years ago and pointed out that lesions, hemorrhagic contusions, are often present in the anterior tips of the frontal and temporal, as we well know, but they also involve shear injuries at the level of the corpus callosum, cortical medullary junctions, and the basal ganglia. And if you look at picture of one patient that we've been involved in his care, you see not only the enlarged ventricles for a 23-year-old man, 24-year-old man, but the encephalomesia, bilateral, asymmetrical in frontal areas, and the same in the temporal lobes. Now, if you look at the literature over what should these areas of the brain produce by way of neurocognitive and neuroaffective disorders, there's been a growing literature emanating from the neurosciences. We know that the orbital frontal areas in pink are clearly involved in the ability to regulate one's emotional responses and to perceive feelings in a way to guide decisions. The ventromedial area, very important also in, we will see in self-reflection activities, and very important in terms of the ability to plan ahead, think, make decisions. The dorsolateral in blue has been repeatedly related to ability to shift one's cognitive set, to think through how to solve different types of problems. While there are many systems for characterizing the consequences of frontal lobe dysfunction, one of the more parsimonious ones have been produced by Mesulam. And you may or may not agree with all of his ideas about this, but for practicing clinicians, these very simple terms highlight what we frequently see. With the frontal disinhibited syndrome, there is this lack of awareness, there's a lack of judgment, there's a lack of foresight. We might say, as Dr. Goldberg was referring to earlier, there's a lack of theory of mind, a lack of ability to anticipate what you are thinking about. In addition to this, though, we get with these large lesions something that Luria talked about. That is a lack of mental tension, was his terminology. We now call it an abulic state, where the individual seems to lack initiative or creativity and has substantial difficulties with concentration. What did we see with these temporal lobe lesions, those involved in the mesial and anterior portions of the temporal lobe? Clearly the hallmark. Many studies emphasize that these individuals show memory impairments, and they're at multiple levels. They're at the difficulties of encoding the information, they're at the difficulties of consolidation as well as retrieval. It is not in a single area. If you switch gears and you ask the question, what has been known, therefore, about impaired self-awareness when individuals have lesions in these areas of the brain? There's been actually a rich literature, but people did not exactly know what they were seeing when they were describing the phenomena. It didn't match up with what they knew. Paul Schiller, who was a psychiatrist, presented a very interesting case study in 1934 of an individual who suffered a traumatic brain injury. They didn't have imaging at that time at all, but we can assume from reading his report there was considerable frontal lobe pathology. The patient had an amputated leg as a result of the injury and insisted that he could use his legs perfectly fine. Schiller, being a psychiatrist, felt this must reflect some form of denial as a way of compensating for the problem. McDaniel presented a patient on so-called Anton syndrome, but it's really what I would call Anton-like syndrome. The individual attempted to kill herself with a bullet to the frontal areas, and so she severed her optic tracts. She didn't affect the calcarine fissure. She severed her optic tracts, was completely blind, and insisted she could see perfectly fine. He notes, though, as at this time, the individual showed many of the acute signs of frontal lobe dysfunction, lack of initiation, certain degree of confusion, childlike behavior, and as those frontal lobe symptoms started to decrease, she now became aware that she was not able to visually see. Her vision had been lost. Coccini, another excellent modern-day researcher in this area, presents a case of a young man that was published in Neuropsychologia in 2002, patient who had persistent hemiplegia and was unaware of it. This individual had multiple lesions throughout the brain, not only frontal and parietal. But you see, throughout the history of studying patients with traumatic brain injury, all forms of neurologic deficits have been either not reported or stated not to exist by the patient, even though it's so obvious to the clinician. For those of us who were involved in brain injury rehabilitation, what struck us was that we saw many of these patients past the period of post-traumatic amnesia who did not necessarily have any obvious neurologic deficit. They had no obvious motor deficits, no obvious visual deficits, but they persistently reported not having as severe a level of difficulty in areas that seemed overwhelming to us as we were involved in their care. Over the years, people have estimated that about 30 to 40% of patients who have initially severe injuries show some form of impaired awareness several months, if not years, post-trauma. What are the areas for which they seem to lack this awareness or insight? Given the anatomy, the first two should not come as a surprise. The biggest problem that we see is the patients being socially inappropriate in their behavior, and when this is brought to their attention, they look at you with a quizzical look as if, what are you complaining about? What are you bringing this issue to mind for? I have no major problem in this area whatsoever, and I'll give you an example of that later. The second, of course, has to do with memory difficulties. I've not yet seen one traumatic brain injury patient that says, please, quick, teach me how to use memory compensation techniques. Where's the psychologist or the speech pathologist going to teach me these memory compensation techniques? They may recognize at some level that memory is a problem, but it is only as you work with them that you are able to progressively, through the context of what I will call a therapeutic relationship, have the patient sense that it may be in their best interest to use memory compensation techniques. Once the techniques are used effectively, there is no doubt that patients do not want to leave home without them. Those memory compensation techniques are extremely important. But my point here is that they do not spontaneously recognize that this is an area that they need to compensate for. A third area that has not been given any scientific attention to, but we see it all of the time, and it doesn't so much have to do with the frontal and temporal lesions, but with the diffuse axonal injuries that we've heard about in previous lectures, is that these patients are slow in their processing speed. Slow getting up in the morning, slow showering, slow getting dressed, slow in doing work. And many of them lose jobs because they are slow in getting the job done. If you ask them, are you slow? Many of them will again shrug their shoulders as if to be not committal about whether or not this is a true problem or not. These variables have been related to outcome of neuropsychological rehabilitation. There's a lack of awareness of difficulties in these areas. We have also seen a few patients who've suffered significant frontal temporal lobe injuries, who were unaware and persistently unaware of their problems 18 years post-injury. We followed two that have developed florid psychotic paranoid states. And I think the natural consequence of severe unawareness in a subgroup of individuals is the development of psychosis, something that has not been adequately studied in the literature. Now, in our early thinking about this problem, we again borrowed heavily from Mesulam's ideas of the heteromodal cortex because they seem to fit in with an early model that human consciousness is not a purely cognitive function. Human consciousness is an integration of thinking and feeling. It is when these two things come together that awareness seems to emerge. When you suddenly have an insight as to solve a mathematical problem, you are not devoid of affect. You say, ah, I've got it. Ah, I see it. When there's true awareness, there's that affective component that is there. So it would make sense that those regions, they would be highly important in the integration of thinking and feeling, would be implicated in various forms of anosognosia and various forms of impaired self-awareness. And in Mesulam's 1985 book, he presented a graph or chart or cartoon, some might say, that would not necessarily satisfy every neuroanatomist or every neuropathologist, but it made a lot of sense for those of us who are clinically working in the field. And what Mesulam simply says is as follows, that you can conceptualize the organization of the brain in cortical regions that in the old days we had the sensory motor systems or the primary sensory projection areas, Heschel's gyrus, Calcarine Fisher, and so forth. And everything else neurologists refer to as association cortex. Mesulam said, let's be more specific. There are regions in association cortex that are unimodal in nature. That is, cells seem to fire primarily to a single type of stimulus or single type of modality, and other kinds of stimuli that are other regions of the brain that respond to multiple different types of sensory inputs. And he pointed out that these areas in pink represent these heteromodal regions. They are the last to develop phylogenetically and the last to develop ontogenetically. He also pointed out what Papes and others had talked about earlier, that there's a region deep within the brain, you see in the mesial surface, which involves the cingulate gyrus, anterior portions, mesial portions of the temporal lobe, and the frontal area, that he referred to as the paralimbic belt. And he said these regions have a lot to do with telling us what's underneath the skin. Am I cold or am I hot? Am I perspiring or am I not perspiring? Am I hungry or am I not hungry? Where lesions exterior in the yellow and pink told us about what was exterior to the skin, which was outside of us. And he points out that everywhere the green is, it is in close proximity to the pink. And we made a big jump years ago saying that it's precisely those areas where there's an integration of heteromodal cortex with limbic regions that you tend to see the classic world's literature on anosognosia. And you saw this, for example, lesions in these parietal areas were commonly associated with anosognosia for hemiplegia. The neuroimaging studies show us it's more complicated than that. The anosognosia for aphasic difficulties often involved the regions involving the angular gyrus and the supramarginal gyrus. And what we thought we were seeing with young adult males that suffered these severe frontal injuries was a lack of awareness of their ability to plan, anticipate, and to perceive changes in affect in themselves as others. As time has gone on, we have tried to rethink this and have suggested the following ideas. If a neurological or neuropsychologic function is dependent, by nature, is dependent on bilateral cerebral activity, then bilateral, almost asymmetrical lesions, as Anton said, is crucial to produce anosognosia for that function. However, if a neurological or neuropsychologic function is dependent solely on a single hemisphere, then unilateral lesions, in fact, in critical areas underlying that function may in fact produce anosognosia for that function. And this is certainly true for anosognosia for aphasia. If a neuropsychological function, and this leads to the clinical management discussion, if a neuropsychological function is widely distributed over bilateral heteromotor cortex, then you need very large bilateral lesions to produce a complete anosognosia. And you see this in the acute stages after traumatic brain injury. This is what Schiller saw. This is what others saw. You talked about the edema. You talked about the multiple areas of the brain that are compromised. Right after the injury, the individual has widespread disruption of regions that are important for memory, important for judgment, for planning, and so forth. But they are not they're indirectly affecting these major heteromotor cortical regions. And what recovery may mean is that those heteromotor cortical regions are able to regain their functional capacity because of diaskesis or the effects of the reduction in cerebral edema or what have you, allows functional areas that look like they were damaged to return back to normal function. Actually, Luria was interested in the same concept, that areas that looked damaged were not really damaged, but they were inhibited in their functional capacity. Now, if you have a more restricted lesion in diffuse areas of heteromotor cortex, so if you have smaller lesions, let's say in the frontal areas of the brain, what happens is that the individual will eventually have some knowledge that that function has been disrupted, but that knowledge will be incomplete. And at that point, you get a very interesting phenomena. When the individual has partial knowledge, they can either use what I will call defensive or non-defensive methods of coping with that partial knowledge. And it becomes very important for the clinician to figure this one out, because it makes a real difference of how you're going to work with the patient and how well the patient will work with you. Many times it is assumed one or the other. It's often assumed the patient is simply in a state of denial without an appreciation that there's a neurological component to this lack of awareness, or conversely, many neuropsychologists will argue that it is purely neurological in nature and not appreciate that there's a psychodynamic or psychological component related to the minimization of a deficit that an individual has. And before I give you two clinical examples of this, I must give you this context. Those of us who work in neuropsychological rehabilitation will have an emotional reaction to the work we do. You will. One of the reasons Dr. Benichet's program was so successful over the years, and we borrowed the idea, is that we met with staff daily to talk to them about how they're going to manage the patient tomorrow. Because we do have an emotional reaction. We get irritated with the patients, we get angry, we get depressed, we want them to get better sooner and so forth. And if we're not managing our emotional reaction to these patients, and we wait 1 week or 2 weeks to have a staff meeting, you've lost the window of opportunity for a meaningful intervention. A very early study by Franson and Myers with monkeys where they ablated frontal and temporal areas, similar, not the same as what you see in traumatic brain injury, but somewhat analogous. Not only did they show in this study that these monkeys would approach the big hairy monkeys without any sense of the dominant status, which is a true problem of social judgment, but what they showed was that when they took these brain-injured monkeys and they put them in with normal monkeys, the normal monkeys had a huge emotional reaction to being with brain-damaged monkeys. I'll repeat that. We're the normal monkeys. We have an intense emotional reaction to doing this work. This reaction can come out and hurt how we treat patients, and I now will give you two examples of that. If one can appreciate, again, the need to conceptualize these problems, I'm going to start off with the more difficult case in which there was partial awareness of a deficit, but there was true denial as well. And then I'm going to go to the simpler case where there was partial awareness of a deficit, but non-defensive methods of coping. The more complicated patient was a young man who suffered cerebral anoxia due to a congenital heart problem. When I first saw him, which was within 5 days of his cerebral anoxia, I examined him at bedside, talked with him, talked with the neurologist, went out and talked with his parents, whose father was a physician, went back in 20 minutes later, and he looked at me as, "Who are you? I don't remember you." It was a true amnestic syndrome, true amnestic syndrome. This gentleman was worked within the context of our neuropsychological rehabilitation, but too early. I am a firm believer that the kind of programs that Dr. Benichet have developed is really most appropriate for post-acute patients. People will disagree with me on this, but my own opinion is, as they are changing rapidly, it is not the best use of our time. There are many more practical things we could do during the acute stages. But when they have plateaued, or nearly plateaued, 1 year, 2 years after the injury, then the holistic programs become very, very helpful. So anyways, this young man comes to our program. He's compliant. He does everything we ask, but when we ask him about his memory difficulties, he says things like, "If I don't use my memory, it won't return back. I have to use it. It's the notion of memory as a muscle. Let me exercise it." The therapist consistently worked with him on a variety of cognitive therapies, individual and group, to try to demonstrate to him that he had a memory difficulty. And with some hesitancy, he would admit, all right, I have some memory problems, but he always resisted the use of memory compensation techniques. Very caring therapists got worn down by this. They got exhausted by this. And one therapist decided to teach the patient a lesson. We sometimes hear the use of a planned or therapeutic failure. There are no such things as therapeutic failures in my mind. But the therapist thought this was a great idea. We're going to teach the patient a lesson that they need to use a memory notebook. So what was done was the young man was told that they had an outing, an activity that they had to be involved in, and he was responsible for buying the hamburger meat that would be used for the barbecue. They, of course, gave him many reminders the day before. They asked him to write it down in his memory notebook, which he said he would, but then did not choose to look at. The therapist was aware that he would most likely not remember, and so she purchased the meat separately. And the following morning, when it was time to go out for the outing, she asked the patient, did you remember to bring in the hamburger meat? And the patient was horrified, of course, forgot, and said, let me run to the store and get it right now. And the therapist said, no. You had your chance. You were given an opportunity to write this down. You could have looked in your memory notebook. We're not going to do this. The patient was literally tortured by this for a couple of hours. And right before the time of the outing, the therapist then told the patient, I knew you would forget it. I remembered it. Here's the meat. The patient was infuriated by this, humiliated by this. And I want to say this is done in the hands of therapists who are knowledgeable and skilled. That's why I showed you the picture of the monkeys, because well-meaning therapists can do some pretty damaging things if they do not know how to manage their emotional reactions to the patient. As we worked with this patient, it came clearer and clearer that he could not accept he had a memory problem because he wanted to go to medical school like his father. And yet he probably was not really of the same level of intelligence as his father, and he probably could have never gone to medical school, even without this cerebral anoxia. But he was so overwhelmed that he could not be called a doctor, he could not be living a good life, that he truly defended against any information that would point out to him his limitations. When we have the psychotherapy workshop, I will tell you about his psychotherapy. I've worked with him now for over 15 years, and there have been different times where we've worked with him for shorter and then longer periods of time. So I know this patient very well, and I know that denial was a key component, and I know the staff responded negatively because he was constantly resisting their activity. So that's one of the key aspects of denial. Impaired self-awareness, there's often a perplexity, not a resistance. But when the patient, despite good evidence, tells you, yes, but I don't need that, then there is oftentimes an element of denial as a method of coping. In contrast, the first patient, who was much easier to manage, was also the son of a physician that had bilateral frontal injury secondary to an automobile accident. He passed all of our neuropsychological tests, and it won't come as a surprise to Dr. Goldberg. And if you look at his imaging, at that time it was CT, not MRI, he had huge bilateral frontal lesions, but he was very bright. So he passed all our tests. His scores were in the normal or average performance, but before the injury they would have been 2 standard deviations above average. This young man was observed one day waiting in the hospital cafeteria to have some lunch. And like all young men who have these injuries, he desperately wanted to have a girlfriend. But he was unable to because he was not very witty. He was not going to school. He was not being able to have something in common, but he wanted a girlfriend bad. So as he stood in line, one day there was a very attractive physical therapist getting lunch at the same time he was, and he stood in line and he stood right up next to her and he smiled. Well, the young woman, of course, was uncomfortable with this, and in all cultures, when women are not interested, they turn their head. That didn't persuade him. As she walked up the line, he walked up parallel to her. and he turned his head towards hers. He said, "Hello." She said, "Hello," and turned her head the other way. This persisted. He was desperate to make contact with her, and he noticed that she had very pretty long hair. And he said, "Your hair is long, isn't it?" She said, "Yes, it's long." He says, it's really beautiful." She says, "Thank you very much." And then he made an inane comment. He said, "Where did you get it?" And she said, "I grew it out of my head." Of which time, from the tone of voice, he knew something went wrong, but he did not know what went wrong. We saw him in group psychotherapy at that time. We used to have group psychotherapy after lunch. Now we have it before lunch because we want to enjoy our meal a little bit better. But at that time, we saw him, and I said to him, I won't tell you his first name, but I said to him, let's call him John. "John, I observed today at lunch, you were standing in line and you were wanting to be friendly to that young woman, but I observed that she was uncomfortable in what you were saying to her. And she really was uncomfortable with how you approached her. And his reaction out of his mouth was, 'You psychologists look for problems everywhere,' okay? And I said, 'No,' I said, 'she really did not appreciate your behavior or comments.' And he looked at me with a look of perplexity, and I'll never forget it. It wasn't a look of defense. It was a look of, I don't understand what you're saying. And we said, how would we know if what you did was not appropriate? And he said, well, if she told me herself, then I would know. And we said, that's asking a lot of a stranger to come and do this. But what if we had one of our occupational therapists, was of similar age, go talk with this lady and get the information, get her view of what happened? Would that be acceptable evidence for you? And he said, okay. And of course, the therapist talked with the young lady. She said, indeed, she was uncomfortable. She was embarrassed. She did not know how to get rid of this guy in the hospital cafeteria. And I'll never forget when this came back to our group work, in the milieu time, when we talked about this young man just looked at us with a look of perplexity and lifted his shoulders, and he says, well, I guess you're right. It's a completely different phenomena, where they have this perplexity over what is going on when you give them feedback, but it doesn't ring true to them. It's what Anton and others talked about. The information doesn't ring true as if it really occurred or it really is meaningful. Where in the other patient, every time we talked to him about the importance of memory difficulties, there was a yeah, but component to it, where there was a defensiveness. So with this, we have found over the years there are certain guidelines that we use when the patient has impaired self-awareness, which is a partial anosognosia, that helps us understand whether or not this is really more of a neurologically based difficulty without a defensive methods of coping with the partial knowledge. As I've mentioned, these patients often spontaneously report these problems. They show little affective reaction to feedback. Our patient just kind of shrugged his shoulders. Universally, these patients seem perplexed with the feedback. And on neuropsychological testing, even though their test scores do not correlate with the awareness, you see the underlying neurocognitive problems that would go with the kind of unawareness that they're referring to. So if they're reporting no problems with memory, you in fact see on neuropsychological considerable difficulties with memory, monitoring their cognitive function, monitoring their memory difficulties. And these patients, I want to emphasize, can get frustrated and may look like they're defensive if the therapist does not know how to manage them. My favorite example on this, if I walked down into the audience and I told Dr. Goldberg, you have a green tail growing off your shoulder, he would smile the first time I say it. And then if I went down again and I said, Nick, that tail is growing off your shoulder, he'd smile again and say, George, it was funny the first time, not the second. If I then said to him at lunch, Nick, you have a green tail growing off your shoulder, he'd say, it's time to stop, George. If I said to him at dinner, Nick, you have a green tail growing off your shoulder, he would find it irritating and he would tell me to stop it. In neurorehabilitation, patients will often be told they're inappropriate, but the patient has no subjective experience of the inappropriateness. So if you simply tell them this repetitively, they will push back, not out of a psychological defensiveness, but out of a frustration of not seeing what it is you're talking about. That is different from denial phenomena, when patients will often spontaneously admit some problems. Yes, I have some difficulty with memory. Yes, I have some difficulty with word finding, but it is unimportant. They will often state that it has no real impact in terms of their day-to-day life. This is the opposite in psychiatric problems. In psychiatric problems, we as clinicians are convinced that the problem is much smaller than what the patient tells us, okay? But in these cases, it is the opposite. They are discounting the problem. Instead of a lack of perplexity over it, they are often very good at being able to verbally defend their point of view about why this problem is not a real problem. And if they're more intelligent than the therapist, and some of these very highly educated businessmen and so forth that have these injuries are clearly much more intelligent than a 22-year-old therapist that is just starting to work with them. They can shred them up easily with their logic. So they oftentimes will produce a negative reaction in the therapist as well as having a negative reaction from the therapist when they give them feedback as to what's going on. It is also interesting to me, and we've really been interested in the whole role of what role does premorbid personality play in these phenomena. And this will be something we will discuss more in the workshop. But Ed Weinstein argued years ago that those individuals that were perfectionistic, that refused to admit to any limitations before their brain injury, were the ones that tended to show these denial phenomena later. Now, I don't think the story is that simple. But I do think if they have partial awareness and their premorbid personality was that they were always in control, no one was going to tell them what to do, then you do see this emerge very clearly in the rehabilitation process. So in terms of the management of these individuals, I would just simply emphasize some of the obvious things. Impaired self-awareness after severe traumatic brain injury is associated with perplexity, and there should be evidence of bilateral cerebral dysfunction in an area important for that function that is now disturbed. In non-defensive INS, patients can be guided and respond to the structure of a holistic program fairly easily. This young man that I talked about responded very well to the templates that was developed in the cognitive rehabilitation, taught him how to speak concisely and clearly, could be easily guided. These patients are actually, I think, some of the more enjoyable patients to work with because they know that you speak the language of brain injury and they do not. They know you know what's wrong, but they can't put words to it. And they're often guided by the experienced therapist. In contrast, those patients in which there's a defensive component to this partial knowledge, they are often the most frustrating to therapists, and therapists have to own this. They have to discuss this openly. Failure of therapists to talk about what patients are really upsetting them is a failure in our clinical leadership of these programs. If the therapist tells you they're never bothered by a patient, then they're not paying attention to the patient. And it is always a mistake to try to teach them a lesson by having them have a planned failure. It just ruptures their sense of alliance with you, which we find over and over again is important. One of the shortcomings of the literature that I see is not an adequate discussion of what is the ingredients of you and I developing a therapeutic alliance with our patients. What does a therapeutic alliance mean? It means that you and I together try to understand how this brain injury has affected you. One of the reasons Dr. Benyusha has been so exceptionally successful is he can take a very difficult patient and develop a bond with him. You and I are going to show the world that you're able to do more than you're actually able to do. They respond to this bond. Now, many people have talked about what is the nature of this bond? What kind of brain function do you have to have this bond? It is the core of psychotherapy, if you use the term psychotherapy or not. It is the relationship between you and I to figure out what is the problem in front of us and what are the next practical steps. I know in this time of technology and neuroscience and so forth, we forget the importance of relationships in the rehabilitation process. But at its core, it's the ability to form that relationship that makes a difference. And here I believe neuropsychologists have to be good clinical psychologists. And clinical psychologists have to be good neuropsychologists. It goes both ways. You must understand if the patient is defensive, if the patient is using denial, there are good reasons for that denial. And you just don't charge in to turn that denial around. You must understand why are they there. And once that patient gets as interested as you are in why the defensiveness is there, then you make therapeutic process. Then they will come back to see you at different times in their life where they have been successful for a period of time, run into problems they have not experienced. They don't forget the relationship, and they don't forget what the therapeutic alliance means, that there's someone else in my life who understands that brain injury better than I do, and who will guide me through this difficult process. So it's within this context that I hope I have set the tone for what we're going to discuss in the workshop and then in more detail later in psychotherapy. And again, I thank you for asking me here, and I hope these comments have been of some help to you.
Thank you, Professor Prigatano, for your very thought-provoking presentation. Perhaps we have time for some questions now, a few questions, and maybe more questions later. So,
I would also like to thank Professor Prigatano for this excellent lecture, and especially for the clinical implications of what was just been said. Thank you very much.
Thank you. Any questions? Don.
I have a question. Back at the turn of the beginning of the 20th century, John Hewlings Jackson pointed out that very often symptoms occur if there's a certain momentum to an injury, but that don't occur if the injury is slow growing. He called that the momentum of the lesion effect.
Mm-hmm.
And these often apply to bilateral damage, not only to the brainstem, but to the cortex. So in the case of where you have slow-growing lesions, where the injury as a result of a tumor or some other disease occurs slowly, but the injury is substantial bilaterally, you don't see any deficits or symptoms. So my question is, in that kind of context, then what does it mean to imply that a particular area is necessary or critical for the evolution or the sustenance of a given behavior?
It's an excellent question and very thoughtful. Certainly the momentum of the lesion does make a difference, and we see anosognosia most prominently following stroke, where there's an abrupt onset. We certainly see it most after traumatic brain injury. However, we see it in other conditions. We see it in Parkinson's disease, where it comes on slowly. And many patients are not aware that they're not moving their limbs as they walk. And you can see the development of anosognosia when the crucial areas are compromised as the disease state progresses, you see. So while momentum may play a role in certain conditions, I think the real evidence, or the real issue, is the underlying neuropathology. Does it tap those neural structures that are crucial for that psychological or neurologic function to exist? You also see anosognosia, of course, in dementing conditions, like Alzheimer's disease. The very common example is in the early stages, the patient knows that there's something wrong, but the family doesn't know there's anything wrong. And as the disease progresses, the famous statement of Stanley Appel was, the patient knows, and now the family knows. And then as the disease progresses even further, his famous statement was, the family knows and the patient doesn't know. So it's not just a momentum problem. It has to do with the underlying neural circuits that are responsible for that function. So the more a psychologic function is distributed, the less likely you will have a classic anosognostic syndrome. But the degree to which the underlying neural network is damaged, you will have diminished awareness. And the question is, then what do you do when you have diminished awareness of that problem? Okay. I had asked people who came to our conference on anosognosia, I asked some people with malignant brain tumors research to come, and they opted out. They say we don't see anosognosia as common with malignant brain tumors. I just have not had enough experience to answer that question. I don't know. But the few cases that I have seen, when the disease gets bad enough, they do have a lack of awareness of the problem. It's a fascinating area because it gives us insights as to what may be, if one believes that human consciousness is the highest of all integrative brain functions, then it raises a very interesting question about whether consciousness is really modularly organized or not, or if that modular organization is only obvious when there's damage to the nervous system, like Hewlings Jackson would say. If in the normal functioning brain, the paradox is that it's modular and distributed. When you have a lesion of the brain, then you only see the modular organization of that dysfunction. Any other comments or questions? Yeah.
Just thank you for the lecture. A small question. What is the origin of the term anosognosia?
Babinski. Babinski has been credited with the term anosognosia. Okay.
It is not a Greek word.
Oh, it is a Greek word, but
Well, the Greek words mean nothing.
pardon me?
Anosognosia is just agnosia. It's quite.
Well, the agnosia means a lack of recognition, of course, or lack of knowledge.
Anosognosia,
But the
what does it-
anosognosia is a failure to want to recognize that one does not know, the anozo. Okay, that's the way Babinski used the terminology. It may be incorrect, but educate me. How would you describe it? What does the word anosognosia mean with the Greek derivative?
It means nothing in Greece.
It means nothing in Greece. Well, I don't know how to.
Νόσο-αγνωσία.
Agnosia is, of course, a lack of knowledge, right?
Yes.
Okay. But the anosognosia refers to a lack of awareness that you lack knowledge. That's how Babinski used the term. Oh.
The Greeks say it should be noso-agnosia.
I see. Okay. We'll have to have a conference in France and talk to the Frenchmen about this and see if we can reverse it. Yeah.
Just to add something, it's a normal phenomenon, nosoagnosia. When you do mistakes, for instance. When you have, we do this in eye tracking, for instance, if you have a target and you have to point it,
Mhm.
the more errors you do, the less you know that you do errors. The more attentive you are not to do errors, the less you know that you do errors.
You lost me. Go over that again. One more time. Go over that again.
Let's say that you point the target
Yeah.
and it's okay. The target disappears and then you point again, it's a bit of an error. And then you are asked, have you pointed correctly or not? And it's very frequent to say, yes, I did. And in fact, you didn't. And the contrary. With saccadic eye movements. If you look at one direction instead of looking the other direction. And so on and so forth. I mean, you always do this and you don't know it.
Right.
And we had some patients like this and we did it. And the less they did mistakes, the more they said they did mistakes.
Mm-hmm.
You understand?
I think I do. Go ahead.
If they did more mistakes,
Yeah.
they had the tendency to say they did not.
Okay.
On the contrary.
Okay.
And that's very interesting because it pointed something like an obsessional character.
Or maybe it has something to do with attention. Maybe it has something to do with attention. I mean, there's an interesting paper in Brain that I was able to participate in, but it was the Italians that put it together. And the title of the paper has to do with anosognosia as a multifaceted phenomena. In given conditions, different variables may be responsible for the underlying anosognosia. There's a growing literature, particularly with Alzheimer's work, that right frontal difficulties play an important role in this lack of appreciation of their memory problems. And there they argue that it may have to do with a self-monitoring component. Okay, there may be a self-monitoring component of which the right frontal area, the dorsolateral area, may be especially important. So in any given condition, any given different type of pathology is another way of saying it, you may have various variables contributing to the phenomena. But the underlying idea that Anton had and that Biziak highlighted is that in the normal functioning brain, this was their idea, the normal functioning brain, consciousness is the highest organization of that functional capacity. This was actually an idea that Roger Sperry stated in 1969. Okay? That consciousness represents the highest level of organization of that function. So while you may get disruptions of consciousness because of inattention or other problems, in the classic anosognostic states, the two most common is for vision and for motor functioning, you always see the lesions in the areas that are crucial for that function to be carried out or to be initiated. Okay?
What I point, in fact, that you do have it like a load, an overload to working attention, to working memory. For instance, if you have to target something and then to say if you did it correctly, that means two things. It's much more than just target it.
Yes, I
And
understand.
so it can be something like an equilibrium between the two.
Yeah, I agree. Also, we find that now, and Luria did the same thing, we find that when we give patients memory tests, we often ask them to predict what they will do in the future. Even in our brief screening tests, we'll say, I ask you to remember 3 words. Neurologists do this all the time. Why don't you remember 3 words? We give them the words. We go over it several times. Then we say, in about 5 or 10 minutes, I'm going to come back and ask you for those 3 words. But then we ask the next question. How many do you think you can remember? Yeah. And this is an important component, because in depression, they'll often say 1 or 2. They will minimize what they can actually do. Where in the more neurological, they say 3 all of the time, and then you go back. They fail, you say, how many again? We're going to try this same again. And you see they cannot integrate that information. They continue to overestimate what it is they're going to do. Now, it's not quite that simple, but clinically we find these phenomena coming up all of the time, and they clearly are related to the long-term outcome. One study that has not been done is how impaired awareness and denial phenomena affect the rehabilitation team, and whether the team stays active and stays involved in this work, whether they go into other areas of work. It takes a toll on the clinicians, and so therefore understanding this problem is not only good for the patients, it's good for us. It's good for us to maintain our energy and creativity in doing the work. Again, thank you very much.